My talk is on loose bag and safe surgery. All the talks have been excellent and very much in time. So at the end of my talk, we can definitely have some questions. So what's a loose bag? A developmental abscess of zonules, degenerative disorders giving you, cases like pseudo-exfoliation, traumatic zonular tears. And when it comes to safe surgery, it simply is careful removal of cataractous lens, long-term stability of capsular bag, and in the event of loss of bag, safe and secure fixation of lens with acceptable visual rehab. When it comes to management strategy, I would like to delay the surgery as long as I can if the vision is correctable with glasses or contact lenses. If you have to intervene, try and preserve the bag as much as possible so that lens implantation is possible. And of course, obviously, in the absence of capsular bag, explore the best options. Pre-operative evaluation is very important. The location of defect, degree of zonules, vitreous in the AC, and presence or absence of phacodosis is important. Obviously, we need capsular supporting devices. There are temporary ones and long-term ones. So iris hook used as pupillary expansion device in small pupil are also used as capsule supporting devices when the zonules are weak. When it comes to timing and number of hooks, if the rhexis can be completed without much of stress on the zonules, hooks will come in soon after the rhexis. In extreme loose bag, capsular hooks come in soon after the first nick in the capsule. Sometimes 4 to 7 hooks may be needed to adequately support the bag until the nucleus is managed. Now let's look at this. This is an extremely loose bag. Less than 25% of the zonules are supporting the bag. The eye is filled with good quality dispersive viscoelastic or viscoelastics like Elon 5. And I very, very carefully continue with the rhexis. At any stage, if I feel that no more, then I would stop, put a couple of hooks and continue with the rhexis. But fortunately, it is possible here. But what comes is after that. Now here, in a loose bag, to get a space to go between the rhexis and the nucleus mass is extremely difficult because the bag is loose, it's all the time moving. So sometimes you have to use a 26 number needle to So if you look at this, this is an extremely, extremely tricky situation in most of these extremely loose bags. It is just that you have to spend time to get some space and get your first hook in. Once the hook is in, then you have relatively good support on the bag, and the subsequent hooks is not really an issue. And in this case, I decided to have 5 hooks to be on a safe ground. So choice between rings and segments, when the zonular loss is less than 90 degrees, capsular tension ring alone will work. When the zonular loss is less than 180 degrees, Sioni's capsular tension ring works well. But when the loss is more than 180 degrees, like in this case, in the presence of weak zonules, CTR in combination with a segment is a safe alternative. Now, in this case, there are extremely weak zonules. I have already planned to go for a segment. I make a Hoffman's pocket. Again, in this case, with a good dispersive viscoelastic, it is possible to make your rhexis. And then the trick is to make a very copious hydrodissection so that your bag is literally separated from your nucleus mass. Then use capsular hooks to fix it. And removal of cataract is not an issue here. Once the bag is completely opened up, then you go in for endocapsular ring, which gives you 360-degree support on the bag, and the bag is little more made taut. And after that, you come with a nano needle from outside and get it in, and with a railroad technique, with a 26 number needle, you take it out. And in this case, I'm using Ahmed segment, and the needle is passed back. And the sutures are, removed outside, and the Ahmed segment is placed with convexity outside, and you loosely tie it. And once the lens is in and the viscoelastic is washed out, the suture in the Hoffman's pocket is tied, and the lens is well centered and the pupil is constricted. Now, this was a case done several years back, maybe 13 years back, when a boy came with a trauma with blood in the AC, blood and bitters in the AC. So this patient at that time underwent surgery. I decided to put endocapsular ring, decided to put Sion's ring at that time. That time, we didn't have the concept of, pupilloplasty for traumatic mydriasis. And then subsequently, when we knew about pupilloplasty, I did try and convince him, but somehow he wasn't very convinced because he had no issue with glare. And then, so when the lens was put, he still continued to have a large dilated pupil. And then he comes 13 years later with the lens decentered. And what has happened is the suture that was a 10-0 suture at that time, it broke and the lens came on this side. So this time I decided to, now it's a loose bag, go with the 9-0 needle and thread it through that central eyelet and try and pull it. And this time I didn't want to miss the chance and do a proper pupilloplasty and get a pupil centered. And with this, although he had, trauma and his vision had never improved, this time and over the years, his vision continued to improve. Now, this patient came recently. He was operated 5 years before, and he had a trauma which led to the bag lens complex, coming into the AC. And I decided to, again open up the bag and try and fix a segment. This time I'm using an AIOC segment, but it was easy for me to get my needle in, but I had to literally separate it because the segment had to sit in it. Under a scleral flap, I use the same technique where the needle is brought out, and then this is an AIOC anchor. It's a beautiful piece. It's like a paper clip. So unlike in an Ahmed segment, your pupil can nicely, slide over it without any obstruction. So here, the clip is tied, and the entire, that anteriorly dislocated bag is pushed back, and the pupil is brought in, and at the end of it, he recovers his vision well. And the last picture at the end of the surgery, when I use glue to close that conjunctiva, is something like this. But then, subsequently that pupil retained its. So these were some of the, pieces I thought I would share with you.